This is the first of a 4-day workshop series where we will explore heart health challenges faced by South Asian communities and ways to prevent them. Today, we'll focus on understanding the cardiology and genetic factors that contribute to the increased risk of heart disease in South Asians. Our expert speakers will help us dive into why these disparities exist and what can be done to address them. We're excited to start this important conversation with you and look forward to going deeper in the coming days. Now, I'd like to invite our partners from South Asian Care to introduce themselves and share a little about their work.
Thank you, Sahini. Hi, everyone. My name is Nisha Udeen, and I'm the founder and CEO of South Asian Care. Thank you so much for being here today. We're really thrilled to kick off this important series with you. As a South Asian woman navigating healthcare, both personally and professionally, I saw firsthand the gaps in culturally responsive care, which is what inspired me to create South Asian Care. Our platform is a digital health resource dedicated to advancing health equity and improving access to culturally compassionate care for South Asian communities. Our mission is rooted in addressing the cultural barriers that often prevent South Asians from seeking and receiving quality care. And we work to increase visibility and representation for compassionate care providers while also empowering our community with trusted, culturally relevant healthcare information. In addition to events like this, our website also features a provider directory where individuals can seek and find culturally compassionate care, a robust educational healthcare resource hub, and other tailored tools to support the health and well-being of the South Asian community. We're so glad you're here, and we hope today sparks meaningful conversations and connections. Thank you. I'll pass it back to you, Sahini.
All right. I want to turn my camera on, but I don't want to mess up the slideshow, so I'm just going to keep going. All right, thank you, Nishat. So my name is Sahini, and I am the Chief Operating Officer of SAHHI. I currently am on the Doctor of Clinical Psychology track and hold a Bachelor of Arts Psychology with a minor in biology. I'm also pursuing a Master of Arts in General Psychology with an emphasis on child and adolescent psychology. I currently work as a paraprofessional supporting students with diverse learning and behavioral needs. In addition to this role, I've worked as a registered behavior technician with children on the autism spectrum using applied behavior analysis. Coming from a South Asian background, I'm passionate about breaking cultural stigmas around mental health and promoting health equity. Through my work with SAHHI, I strive to develop inclusive, culturally responsive programs that address both mental and physical health, emphasizing the connection between psychological well-being, nutrition, exercise, and genetics, which are all just a few key factors of what the South Asian Heart Health Initiative does. Now I'm going to speak a little bit about Hibba Siddiqui, our Chief Executive Officer. Hibba Siddiqui is the co-founder and CEO of the South Asian Heart Health Initiative. Hibba Siddiqui is a summa cum laude graduate of Benedictine University with a Bachelor's of Science in Health Science and a minor in Medical Spanish Interpretation. Hibba now works at Dana-Farber Cancer Institute and Harvard Medical School, where her research explores bladder and prostate cancer. Passionate about merging science with community impact, she has organized national workshops on preventative health, published articles on health equity in outlets like the South Asian Herald, and spoken at conferences including Girl Contact. Her leadership has earned recognition such as the Benedictine University Community Service Award and election to the Board of Directors for Massachusetts Association for Women in Science. Hibba's vision for SAHHI stems from her belief that prevention begins with culturally resonant education. Through this summer series, she aims to empower South Asian families and anyone interested in holistic wellness with practical evidence-based tools for lifelong heart health. The speakers that you will be hearing from today are Dr. Rish Chaudhury and Ms. Akshata Nayak. Today's workshop will include 2 important sessions. Session 1 is the Ethnic Heart Health Crisis, presented by Dr. Rish Chaudhury, a cardiologist. He will discuss why South Asian populations face higher risks for heart disease, exploring genetics, lifestyle factors, and cultural influences. Session 2 is Gut Health, Nutrition, and Heart Disease Risk, led by Akshata Nayak, a nutritionist and integrative health expert. She will cover how gut health impacts cardiovascular risk, common dietary patterns in South Asian communities, and practical ways to improve heart health while honoring cultural traditions. Before we jump into our first session, we're going to start with a quick and fun icebreaker to warm things up. You'll see a link in the chat right now in a few minutes. Once you do, go ahead and open that up. It's a South Asian Heart Health Bingo card, and whether you are South Asian or not, we want to see how much we can all relate to one another. The first person to get bingo and shout it out in the chat will need to show their completed card to confirm. Then they'll receive a gift card sent directly to their email as a thank you for joining in. The email will be given to us from the winner via private message on this Zoom link. This is just a lighthearted way to connect, laugh a little, and remember that cultural habits really do shape how we think about health. I will now be sending the link. So I'm going to give everybody a few minutes to join it, and then we'll get started. We haven't started yet, but I do hope you win.
Oh, whoops, I'm sorry.
So if everyone just presses on the link, it should take you all to a bingo card. And then just a minute or so here, I'm gonna start calling them out. First person to get a sequence of any sort will be the winner. And then I'll need to see your card to make sure that you did win and so that you can get your prize.
Wow, I totally misunderstood this. I'm so sorry.
Oh no, you're fine. I may have explained it weird. Could be my fault. So let's just give everyone one more minute. And you can either message in the chat that you got bingo, or I will enable you to be able to unmute yourself to let us know that you got bingo. All right, is everybody ready? Okay, let's start. The first one I have is heard haldi can fix anything at least once. So if you've heard that, haldi is turmeric. It's known as an antioxidant things in the South Asian communities. Lots of our ancestors believe that that is the cure to everything. So the first one is heard haldi can fix anything at least once. If you have that, mark that down. The next one is free space. Everybody has a free space, so if you have that, mark that one. The next one is been told it's all in your head, think positive. Been told it's all in your head, think positive. Right, the next one we have is been told homemade food can never be unhealthy. Okay. All right. So, can you tell us which ones you got in a sequence? You can unmute yourself. Oh,
Got it. Yes. Been told homemade food can never be unhealthy. It's all in your head, think positive, and free space.
okay. If you can just screenshot that and
Yep.
try to would you be able to send that in the chat?
I will try. I've never done that, but why
Okay,
not?
yeah, just try to send it in the chat so we can all take a look. Okay, wonderful. We actually have your email, so you'll be getting your gift card to your email. So congratulations on winning our very first icebreaker. I hope everyone had a little bit of fun with that and got to take a look at all the bingo cards. But just so everyone can kind of hear everything we have on there in case it wasn't on your bingo card, I will just take a minute or two to just finish reading a few more. The next one would have been heard just pray it'll go away about literal medical symptoms. Heard just pray it'll go away about literal medical symptoms. I wish everything left our bodies that way. Um, Next one is ate rice and roti in one meal. That would be a lot of carbs. Ate rice and roti in one meal. Next one is watched someone's blood pressure go up during the family drama. My mom always tells me that me and my sister are the reason for her blood pressure to go up. So, next one is, oh, bingo. Well, if you want, you can send your screenshot of your card, but we do already have a winner, but we're glad that these are pretty relatable because I can relate to them too. The next one is pretended ghee doesn't count because it's good fat, right? Next one is heard put Vicks on your chest, it'll help the pressure. My grandpa thought that would help with absolutely anything. So even if I was throwing up, he thought Vicks was the answer. But yeah, those are, I think, everything that I had on there based on what you got. So congratulations, Miss Nayak, on actually winning your bingo. So I'm going to screen share again so that we can continue. All right. We will begin with Dr. Rich Chaudhury, a cardiologist and public health expert. He will provide insight into the ethnic heart health crisis, explaining why South Asians face higher risks due to genetics, lifestyle, and culture. So, Dr. Chaudhury, I'm going to give you the rights for sharing your screen for your presentation. And then when you are done, if you could just pass that right on to Ms. Nayak so she can share her screen. All right, you were made host now.
Awesome. Thank you so much. Those bingo cards are definitely relatable. I think pan South Asia. So it's really great to be here. Let me just take 1 second to share my screen. All right. Hopefully everybody can see this. Yeah. All right. So thank you for the introduction, Sahini, and thank you to Nishat and Hiba for allowing me to be here. This talk is very pressing, as I'm sure a lot of you know that the heart disease epidemic is running rampant in South Asia. So it's a very timely talk, and I'm glad that organizations like SAHHI and South Asian Care are doing the due diligence to kind of spread the word and raise awareness. And then I think accidentally the end of this talk will transition really nicely into Akshata, what I'm sure you might be talking about after this. So like I said, again, thank you. It's a pleasure to be here. The presentation I tried to gear toward kind of varied levels and exposure to medical literacy. But luckily we have a small, intimate group today. So if there's anything that someone finds confusing or has a question about, please do not hesitate to either throw it in the chat or just unmute themselves and kind of let me know. And then there are a few little questions I have here that are interactive. And so if at any point throughout those you have any thoughts, I'd love to hear them. And like Sahini mentioned, my name is Rich. I'm one of the cardiology fellows at Mass General in Boston. Hiba, I didn't know that we were neighbors. So it's great to connect. I've done a lot of public health research. My area of interest is South Asian cardiometabolic disease, and I've done a lot of work in India, and then also here with the Our Health group, which I'll talk about toward the end of the study or the end of the presentation. But our focus mainly is trying to understand a lot of the risk factors and causality relationships that influence why South Asians have such higher rates of cardiovascular disease than sort of other populations in the world. And so the inspiration for this talk, I don't know if I'm outing myself, but if there are any other Bollywood fanatics here, this quote I find particularly relevant. It is from a movie, I think in the 90s, but basically the heart refuses to listen. So that is the theme that I'd like us to kind of carry with us for the rest of the talk. Just given that it's such a powerful, large epidemic that's happening right now. And what I'll start with basically is that unfortunately, most of what is driving kind of the increased incidence and prevalence of cardiovascular disease in South Asia and among South Asians abroad in the diaspora still remains to be understood. But there's a striking statistic here from the Indian Heart Association, which is one of the public health bodies in India, that even though India has about a fifth or 20% of the world's population, Indians bear 60% of the world's heart disease burden, which is extremely frightening and striking. And that number is expected to grow kind of in the coming decades as India develops. And we've seen that this pattern is there for other countries in South Asia, particularly Bangladesh, Pakistan, and also within the South Asian diaspora, living in countries like the US and the UK. And so this is me on the right, if you can imagine, often frustrated by a lot of my patients kind of relating to the bingo chart, a lot of their preconceptions about their health. And basically, I think what we see is that a lot of South Asians, particularly in the United States, ask kind of, why me? Why is this happening? Why am I at higher risk? And why is my health deteriorating? And so most of this talk will be kind of focused on answering that question. Stepping back, I think obviously I'm a cardiologist, and so I don't want to get too technical, but heart disease is an umbrella term that we really throw around, but I like to break it into kind of three buckets. The first being the electrical system of the heart can cause disease. We have a kind of like an electrical superhighway in the heart that causes it to beat throughout our lifetime. When that stops working, the heart stops pumping, and then people pass away. And so that's a critical system. The other thing is the vascular system of the heart. These are the arteries that supply the muscle of the heart, causing the heart to be able to pump blood through the rest of the bodies to perfuse our organs. And then also we can have issues with the pumping function of the heart. Issues with that is called heart failure. And then also people can have a lot of valvular issues also. When we think about heart disease in the traditional sense, and when we talk about it, particularly within the context of South Asian heart disease, we really are talking mainly about vascular disease. These are kind of traditionally what we think of as blockages from plaques within the arteries that cause heart attacks. And we'll see that in just a second. But that's to say that issues with the blood supply through the vascular disease or the vascular system of the heart will impact both the electrical function and then also the pumping function and the valvular function of the heart. So they're all intertwined. But the main focus is mainly kind of because what's most common is issues with the arteries in the vasculature. Okay, so most cardiovascular disease, by far, and we'll see this, results from damaged blood vessels from cholesterol plaques. On the left, there's an artery. Arteries take blood away from the heart and bring it to the tissues of the body. They're thick muscular vessels that have different layers and kind of pump blood flow from the heart to the periphery. And gradual cholesterol plaques can cause what we call atherosclerosis on the edges in one of the particular layers of the vessels, which causes narrowing, and that can lead to clots and to form that obstruct blood flow and cause death of the cells that artery is supplying. And when that happens in the heart, as you see here, that's called the disease in the vessels is called coronary artery disease. The arteries that supply the heart are called coronary arteries. And then when people have cholesterol plaques in them, we say that they have coronary artery disease. And acute obstruction of those vessels because of the plaque buildup is called a heart attack. That's kind of what the lay term is. In medicine, we call it a myocardial infarction. But that's kind of an obstruction here will cause death of the whatever area that vessel is supplying, which can create all sorts of problems. Okay, and then we have arteries, obviously, in the rest of our body too. The same thing can happen in the brain. That obstruction is called a stroke, and then also in our kidneys, legs, arms, any cholesterol or plaque buildup causes issues. But the two main things that we're talking about that you kind of hear about are heart attacks, which is in the middle, and then strokes on the right. Just zooming out and thinking about the kind of scale of heart disease around the world, I think it's probably not a surprise at this point that cardiovascular disease is the leading cause of death in the world. About a third of all global death comes from heart disease. It's the number one killer by far. And about 500 million people have heart disease. And I think that's an underestimate. And basically, most of that disease is due to ischemic heart disease. Ischemia means that because of blockages, that tissue is starved of oxygen and nutrients that the blood is bringing it. And most of that is due to ischemic heart disease or heart attacks and then stroke. For many reasons, 75% of cardiovascular disease happens in low and middle income countries, of which South Asian countries fall in that category. And cardiovascular disease, not just in terms of death, but it also is a really big share of, it causes a lot of disability. And we measure that in research as disability adjusted life years, which essentially is a fancy statistical method of measuring the burden that a particular disease causes in terms of the effect that it has on the length of life and also the quality of life. And so what we call DALYs kind of represent the total amount of life lost due to ill health, disability, premature death, quantifying kind of how much healthy life is lost due to a specific disease or condition. And this is what that looks like graphically by the numbers. South Asia, right? These countries here in the top kind of are toward the top in terms of the amount of disease mortality that we have. And then the United States, where we are, is significantly lower than that on that graph. And so, even though Russia is at the top and South Asia is not the number one, South Asia really outperforms all the other countries in terms of thinking about the relative risk of heart disease. Russia here, for example, has a high age-adjusted mortality rate from cardiovascular disease because their population is older. But South Asian countries, on the other hand, we have a higher relative risk of cardiovascular disease. We have younger population structures. The median age in South Asia is something on the scale of like between 30 and 35, depending on the country. And we have premature cardiovascular disease death that is miles ahead of any other region. And then also a lot of non-fatal cardiovascular disease. People have it, but then they don't die from it because they get an intervention. This is what that looks like graphically. I think, you see the blue areas, meaning the disability from cardiovascular disease is less. And that's mainly kind of in the industrialized Western world, the United States, the Americas, Europe, and Australia, Japan. I think that's a surprise to no one, but there's just a bunch of red kind of in Central Asia and then South Asia. And breaking down what that looks like, the main takeaway from this chart is that most of the disease comes from ischemic heart disease, heart attacks. that is kind of the pink in these graphs. And South Asia here, from a disability adjusted life year perspective, is kind of toward the top. There, of course, are other kind of causes of heart disease, kind of like what I talked about initially on one of the slides, but really ischemia, meaning kind of blockages in the arteries, account for the vast majority. Other ones here that you might have heard of, hypertension or blood pressure, alcohol, atrial fibrillation, which is a rhythm problem, sort of infections in the heart and other things are also there, though, just to note. Thinking kind of more locally in the United States, the problem is, probably pretty obvious to us, but it's, again, pretty similar. It's heart disease is the leading cause of death by far in the United States. It accounts for 20% of all deaths. Again, outmeasuring kind of every other disease or kind of cause of death. Cancer would be the second, but that's by far lower than heart disease. About close to 750,000 people died from heart disease in 2022, and that number continues to rise. That's about one person every 33 seconds dies in this country from heart disease. And I think we might expect that. Americans have the reputation of maybe leading more unhealthy lives. The obesity epidemic, which we'll see in a second, is incredibly relevant and in the news. This picture to the right kind of looks at the distribution of that cardiovascular disease throughout the country. And I think it's kind of easy to deduce that this area here, the southern part of the United States, lights up very red, in that the disease rates are strikingly high in different parts of the country, particularly in the south, where medical literacy is lower, obesity is rampant, and kind of lifestyle is not conducive to good cardiovascular health. Thinking through that and zooming back into South Asia and South Asians in the United States, the striking thing that I think is at the crux of this problem is that research kind of across the board has demonstrated that South Asians, compared to basically any other population, we are having about double the risk of cardiovascular disease than Caucasian or white populations, and that happens in us at significantly younger ages. The median age in terms of when people are getting their first heart attack or myocardial infarction is really on the scale of like 6 years earlier in South Asians versus others, and really other research has borne out that this is an underestimate. The real likely difference is really probably around 10 years, and so. When white Americans are coming to the hospital with a heart attack, they might be 60, 65, but we see in clinic all the time patients in their 40s, early 50s having these issues when those patients are of South Asian descent. So this is very real. And it's not just a problem limited to South Asia, even though you might think that the infrastructure medically is less developed in South Asia, and maybe these problems seem a little bit more obvious, but it actually bears out in the diaspora also. So we're seeing this pattern of disease in South Asians in the United States, Europe, the Middle East, and it remains poorly understood, but there's something genetically linking that, something genetic that carries when people leave South Asia and then emigrate elsewhere. So, like I said earlier, this phenomenon is well studied. The UK, the NHS in the UK keeps a very robust biobank, they call it, it's a repository of patient information. And this is from a study that was published a few years ago in one of the larger cardiology journals. But it's true that South Asians have a 2 times higher risk of myocardial infarction than Europeans. And it's not captured in traditional risk calculators. And so the 2 graphs B and C on the right, basically, when you go to the doctor, when you go to your primary care doctor, they, when thinking about whether to start you on a cholesterol lowering medication or aspirin or something for diabetes, we have all these tools based on research that we use to kind of think about risk stratifying people and using guidelines to determine who needs therapy or more aggressive intervention. And 2 of these tools were used on the right, where South Asians and Europeans, if you just plug in the numbers, kind of age, smoking history, diabetes, high blood pressure, the expected or predicted rate of heart disease was basically the same in both groups. Um, and but when you measure it out, when they followed South Asians in the UK across a 12-year time period in graph A, when you looked at the incidence, despite the calculator saying that there was no difference, South Asians were actually having heart attacks at double the rate of everybody else in the UK. And that's a real bummer because the tools that we use to kind of predict this risk, never included South Asians in the calculus, and so most of those tools were built using kind of Caucasian populations, and those tools don't account for the higher risk that South Asians had that we saw kind of borne out when we actually went out and counted the number of heart attacks that people were having. And so in graph A on the left, you can see that the blue line is people of European ancestry are getting, across a 12-year follow-up, are getting incidence of heart disease at some level, and South Asians in the red line are way ahead of that, more than double the rate. And so that's a real problem. And additionally, since 1990, there's been almost a twofold increase in the amount of deaths from ischemic heart disease in South Asia. In 1990, 1.5 million people were dying of heart disease a year in South Asia, and now it's almost 4 million. So that's a significant increase. And as you can see in the bottom, that most of those deaths were from ischemic heart disease, but then also stroke was a big one, and that also accounted for a lot of morbidity and mortality. And interestingly, it's not just South Asia, it's also the United States. This graph plots deaths from cardiovascular disease across the last century. And, in the 1900s, as you can imagine, the life expectancy was lower, the diets were much better, people were active, had to, essentially go out and, they were very active in terms of their jobs. And so the rate of death from heart disease was much, much lower than it is now. And then toward the turn of the century in the 1950s or so, that number kept increasing sharply to the point where the United States, the NIH and the United States government devoted a lot of money toward studying this. And most of the initial trials in terms of understanding heart disease started kind of in the 1950s after World War II, with the Framingham Heart Study and other studies like that. And so that's responsible for kind of that plateau and dip in the number of deaths across the 70s, the 80s, and even early 2000s. And then kind of in the 2000s, we had better technologies in the hospital, medically, better medicines coming out, better practices for stenting, better surgical techniques, which brought that number low, but we're seeing it pick back up again. And even after COVID in 2020, that number continues to rise. And so something is happening, not just among South Asians, but in the world, in the United States, where our lifestyles, our diets, something is happening where this number continues to rise again, despite a lot of the research and billions of dollars that were pumped into understanding these diseases and trying to treat them. And so my first question for you to kind of frame the next few slides is, I'm curious to know if people know some of the traditional risk factors for heart disease. And what have you heard? What have you seen on TV? What are your families talking about? And were you surprised about any of them? And so if you want to throw some ideas in the chat or unmute yourself, I'd love to know kind of what you're thinking and kind of where our awareness is in terms of what are risk factors that are causing this problem. Yep, smoking. That is a very, very big one. Probably not surprising though. Anyone else have any ideas? Sedentary lifestyles, exactly. Exactly. I think things that we think about, diet, etc. Yep. People are not really farming anymore. People are not going out and working. Everyone is sitting at a desk for 10, 12 hours a day and then going to bed and sleeping for 8, 10 hours a day. Yeah. So we're not really moving our bodies. Those are all great thoughts. And so stress, mental health, stigma, those are great, Hiba. Thank you. Those were great. Maybe not as traditional, but super relevant. And there's a lot of research that show that a lot of that is contributing as well. Okay. And so when I think about these traditional risk factors for heart disease, vascular disease, I lump them into four buckets. The first bucket is modifiable risk factors, things that we can change. The second is non-modifiable risk factors, things that we cannot change, things that we're born with. The third, comorbidities, other medical conditions that put you at a higher risk of heart disease. And the fourth is social and environmental factors. Hiba, something that you hinted at in your comment there. The modifiable risk factors, I think, might not be too surprising, but kind of like some of what you guys have mentioned, unhealthy diet, physical inactivity, excess alcohol intake, smoking. Those are things that people do that they can change, that put them at a higher risk of heart disease. Non-modifiable risk factors, things that kind of we're stuck with, things that we don't focus on when we try to decrease a patient's risk of heart disease because we can't do anything about it. Genetic predispositions, and we'll see that in a bit with South Asians, but race, ethnicity, gender, age, obviously we cannot change. Comorbidities, I think this is something, high blood pressure. I think I'm not sure if the general public really knows that high blood pressure puts people at risk for heart attack and stroke. I think they know that it might kind of affect their eyes, their kidneys, might cause headaches, but really people might not know. But the other big one, even probably new research suggests that diabetes is probably even a bigger risk factor than a lot of other things. But we just published a study in our group that 75% of the world does not know that diabetes causes heart disease, and diabetes rates are rising. Hyperlipidemia, high cholesterol, I think that's maybe something that people think of. That's a buzzword when people think about heart attacks and strokes. Obesity. Chronic kidney disease, people don't know. And then any conditions that put you at a higher inflammatory state, like multiple sclerosis, certain autoimmune conditions cause the body to have a lot of inflammation, which causes weakness in the vessel wall. And then infections, also chronic infections, put people at risk of heart disease. And then, newly studied is that really there's a lot of social and environmental risk factors too. Anxiety and stress. Someone mentioned that. Dysregulated sleep, we're going to see in a bit. Sleep is huge, such a huge risk factor for heart disease and stroke. And, there's been study after study in the last few years that have looked at kind of people that work night shifts and, doctors who are always in the hospital not sleeping, that our rates of metabolic syndrome, heart disease, stroke are much higher than the normal population. Air pollution. This is going to be big, particularly in South Asian countries, outside of the US, although there are certain areas in the US that also have problems with this, particularly those that are in industrialized areas like Detroit or other places where there's a lot of smoke emission. Poverty, I guess pretty maybe obvious. Social isolation, loneliness. This is a big epidemic in the Western world, especially in the United States. And then also, we also just published a paper in one of the big medical journals about weather, extreme weather, like what we're seeing with climate change, global warming, drought, famine, really high temperatures also put patients at risk of increased incidence of heart disease and stroke. Okay, and this is kind of like what that would look like in terms of the numbers. The middle one is probably something that we're more familiar with, the metabolic risks. Again, the pink here is ischemic heart disease or heart attack. Coronary artery disease is the biggest one here, by far the biggest killer. But high blood pressure, cholesterol, high BMI, high fasting glucose, kidney dysfunction, kind of all of what I just told you. On the left, environmental risk factors are huge. Look at the first one, is basically pollution. That by far, more than double the next one, is contributing to a lot of this increased incidence of heart disease that we're seeing, especially in South Asia, India, Pakistan, Bangladesh, and elsewhere. Okay, lead, low temperature, high temperature, kind of those extreme conditions that I told you about. And then behavioral risks on the right. Obviously, diet is massive, even more so than smoking, and then alcohol use, and then low physical activity, maybe not as contributory as we think, but we're going to talk more about that. And I think some of these factors are surprising, but maybe some are better understood and known kind of by the general public. Here's kind of I think the big thing that is getting a lot of attention lately in the media. I think it's just really striking that I think a lot of the world views America as fat, But when you think about the number, 3/4 of the US is now overweight or obese. Okay, so this is basically when we see patients in clinic or in the hospital, by default, they're overweight or obese. There's no one really that walks in that has a normal BMI, which is striking. Um, and you think that, I think the Western conception of South Asia is that people in India or Pakistan are starving, there's famine, there's malnutrition, but really with the rising middle class and kind of increasing wealth that's moving to South Asia, um, the same thing is happening, at least in India. Really, 200 million Indians are now overweight or obese, and that number is going to grow exponentially in the next few years. Okay, and when we're saying that all these things genetically are also kind of out to get us in terms of heart disease, obesity is not going to help. Okay, so we're sitting on an epidemic of massive proportions that healthcare has never seen before in terms of heart disease incidence. Okay, so the countries are actually not as dissimilar as you'd think. Um, Now, the thing is, though, is that South Asians have higher, kind of the driver of this talk is that we have higher rates of cardiovascular disease at earlier ages and lower BMIs. And I'm going to kind of outline what I'm going to talk about the next few minutes, but there are several reasons for this. And this is maybe the kind of key slide of this presentation, but there are genetic and biological factors that put us at higher risk. We have higher rates of insulin resistance, meaning kind of diabetes, and then central adiposity is not just obesity, but a lot of South Asians carry, the typical picture of an uncle at a party is that their stomach goes, 2 feet in front of them before you see their face. And so that is the image of an Indian uncle, is that we have higher rates of fat in the abdomen, and that fat is metabolically active, secreting all sorts of hormones that are going to drive a lot of metabolic processes in our body. Okay, and we have higher rates of cholesterol issues, which I'll talk about kind of on a later slide. We have higher rates of traditional risk factors, kind of similar to what I just said, but diabetes, high blood pressure, fatty liver, the whole metabolic syndrome. And then we also have, for some reason, increased vessel wall dysfunction in the endothelium of our vessels that are prone to lipid plaques forming there, and more inflammation in one of those walls in the arteries that we were talking about earlier. And that is by far very incompletely understood. Our dietary patterns, similar to what we saw in bingo, higher intake of refined carbs and trans fats, right? We're having, a naan that has dozens of grams of carbs, 400 calories, with ghee lathered onto it, right? A lot of trans fat, and then lower intake of fiber and omega-3 fatty acids, which are good for the heart. Maladaptive lifestyle patterns. I'm going to show you some pretty convincing data in a bit. But as India and other countries in South Asia have shifted to having a growing middle class with more industrialized developed economies, we were all farmers 100 years ago, kind of, working in the fields. And now, like I said, everyone is sitting in, at their desk doing work for 20 hours a day. No physical activity, very sedentary lifestyle. There's some epigenetics and childhood factors that play a role too. This is kind of less understood, but people who have poor nutrition earlier on in their life and then undergo some sort of economic transition where they're now eating very rich foods, our bodies are not able to process that as well. And then also kind of what we're going to talk about in a bit, what we hinted at, exposure to chemicals, air pollution, extreme temperatures as the world is changing from an environment and climate perspective. There's a lot of psychological stress in immigrant communities. There was in the bingo about blood pressure being high, but, coming to different countries from your own is associated with a lot of stress, which causes increased cortisol production that lingers for actually not just your life, but also generations beyond you. And that is going to cause a lot of problems. And then lastly, South Asians, we do not like to go to the doctor. There's a lot of underdiagnosed issues and a lot of delayed treatment. You can think about your people in your own family. People, at least that I know in my communities, will not go to a doctor until they start feeling chest pain or they're curled over and they're having a heart attack. People don't care about getting their cholesterol checked at an early age, and even if it's high and the doctor's saying to do something about it, they ignore it because we have a very short-term kind of focus with our health. Sorry that I'm just catching up on the chat here. Akshata, I didn't mean to neglect, but just extreme weather. I can talk about that in a second. And then, so common to hear that he was perfectly fine, but came out with it. Exactly. People are fine, then they go to the doctor, and then they, oh, that doctor found all these issues, and now I'm kind of, disabled or whatever. We see that all the time. Yeah, your comment about extreme weather affecting heart disease, it is because a lot of the, so stress, pollution, all of that stuff. But it's also, there's some link between kind of, when you have famine or extreme heat or cold, the body's stress response, there's cortisol production and increased kind of inflammatory markers that get secreted, and it puts a lot of strain on the cardiovascular system to kind of survive those episodes. And patients with weaker reserve will then kind of flip into having heart attacks or kind of worsening outcomes. It's a trigger for kind of a lot of, people who have, plaques in their arteries that then undergo a stressful event will then develop a heart attack. Exactly. So thinking about risk factors, there's great data that South Asians have way more of them. Okay, that's the point that I'm trying to drive in, is that it's striking. We have a 6-time higher risk for developing diabetes. Okay, this data also comes from the UK Biobank, that cohort from earlier that I showed you, is that, we have on the left, 5.3% of European origin UK citizens went on to develop diabetes, where 19.5% of South Asian Europeans have that. That is 4 times the amount. Okay, and Bangladeshis were by far the worst. 30%, 1 in every 3 Bangladeshi citizens in this cohort went on to develop diabetes, which is absolutely mind-boggling. And the problem is that those that got diabetes were not all fat. South Asians have increased rates of diabetes, what we call lean diabetes at a normal or slightly abnormal BMI. Okay, so on the right, diabetes without obesity, 45% of European diabetics did not have obesity, were compared to kind of 2/3 of South Asians that had diabetes without an obese BMI. Okay, and then great data here. I don't know if this is surprising or not, but Indians are physically unfit. About half or even more, there was a study in Lancet, one of the big medical journals a few years ago, is that we are not meeting the WHO targeted requirements for exercise and physical activity. We are actually doing very poorly at it. So this is a graph here, a chart here that shows that about 50% of us are not meeting that, compared to kind of other countries that are doing much better. And so there's data for that. That was something that someone threw in the chat, that yes, the answer is yes. Physical inactivity is a huge risk factor, and South Asians are doing much poorer than others. And then something else that I find really interesting is that we're more frail. South Asians are more frail. This is, again, data that comes from the UK. Our elders, and you might see that at family functions or parties, is that as South Asians get a little bit older, past 65, they start to look a little bit more frail and decrepit than maybe white people or other people do at the same age. And we don't know why that is, but that's clearly contributing to the heart disease epidemic. If you look at this graph here, 40% of Bangladeshis in the UK after 65 are frail, and frailty is kind of a medical assessment. There's very clear definitions of what meets frailty, but 40%, I mean, at age 65, hopefully the goal would be, as you retire, you can kind of enjoy some of that time, walk around, go on vacation, do activities, spend time with children, grandchildren. But 40% of them are frail, compared to white and black UK citizens, where that number is much less. Okay, and this is the odds ratio from that study, but even when you adjust for things like age, BMI, or other things, that number gets a lot worse. And so the odds ratio for Bangladeshis in the UK, they're 3 times more frail when adjusted and compared to their white counterparts. Indians, 1.6 times more frail. Pakistanis, 2.4 times more frail than their counterparts, and that's something that's significant. Sorry, I'm trying to catch up with the chat here. Awesome. Okay. Um, yes, yeah, frailty. Definitely something that is that's interesting and now being studied. This is also a kicker. Anyone, I don't know if anyone is North Indian or comes from Pakistan or Bangladesh, but not as much of a problem in the south, but in the plains of the north, air pollution is a hot topic, something that the government argues about constantly, but still persists despite a lot of our interventions. Delhi, it's where my family is from, and I love the city. And it's so sad to see that this is kind of Delhi has been branded as the air pollution capital of the world for the last 10 years. The AQI or particulate matter there is, at its worst in November, that post Diwali season. That air is akin to breathing 40 cigarettes a day. Okay, which is insane. Okay, and then when you look at that news article, when you look at that news article on the left, 1.67 million people in India died in 2019. 17.8% of deaths could be linked back to air pollution, and a lot of that is because fine pollutants, PM 2.5 particularly, will go into your arteries, cause inflammation, cause plaque to form, and then cause those plaques to clot, causing heart attacks and strokes. Okay, so this is a direct link between the environment and industrialization causing heart attack and stroke. Okay, and that's like I said, not just South Asia, but Delhi is the epidemic, the hotbed of this. Okay, so it's a newer risk factor that we haven't had to deal with in the earlier parts of the 20th century, but is now very big as more of these countries start to develop. Okay, so all in all, basically the take home from the risk factor perspective is that we have more of them. Sedentary lifestyle. This is a study that looked at all of these factors again from the UK, and even though we smoke less actually than Europeans, we have a lot of these other risk factors that translates into increased risk of heart attack and stroke. Okay, so the second question I'll ask is if people know anything about cholesterol. It's something that I've mentioned a little bit. Something that I'm sure many of us have gotten checked at the doctor, and kind of we don't know what to interpret. But what have you heard? Are there different types? What are they? And how does it link to heart disease? I've mentioned a little bit, but curious to know your thoughts. Okay. I think for the sake of time, yeah, they're good. Yep, Nishat, they're good and bad types. Exactly. Um, all right. So what is it? Cholesterol is a molecule. It's a steroid-like molecule that is essential to the function of our bodies. It is how we make our cell walls, and it's really important for the function of our hormones and then also in our nervous system. When we think about cholesterol, when you get your cholesterol checked at the doctor, you're going to look at kind of a number that is a total cholesterol of around 200, above that being abnormal, and the LDL or bad cholesterol, which we'll see in a second, usually the upper limit of normal is around 100. When we're babies building a body in our mother's womb as fetuses, keep in mind I said so 100 to 200 range. When we're babies making it, our whole body is forming one cell, two cells become, a whole billion trillion cells. We really only need about 10 of cholesterol. Okay. And what we're having now, we're seeing people have hundreds. Okay. But really just 10 of circulating cholesterol was enough to create from two cells to create a baby. And that is made in our liver. We don't really need to eat it. Okay. And so that's what I'm kind of saying is that even though we think that the numbers in the lab are like, oh, it's less than 200, it's fine. We don't, that excess cholesterol that's coming from our diet that's sitting in our blood is not doing anything except causing issues. Okay. Low density lipoprotein or LDL is the bad cholesterol. That's the stuff that's going to build up in our artery walls. That's going to cause inflammation, narrowing, and blockages. And the way to remember that is LDL, you want low. That's bad. HDL or high density lipoprotein carries LDL, the bad cholesterol, away from artery walls and it gets recycled and broken down in the liver. That's why HDL is the good cholesterol. So you can remember the H in HDL, you want it high. Okay, so that would be the best. Triglycerides store excess fat from our diet. These are this circulating fat that we're eating before it's broken down. And the recipe for disaster here is high triglycerides, low HDL, and high LDL. That's all going to give you increased risk of heart disease. And the worst one there is the LDL. Okay. I'm just reading the chat. Protein diet. Yes. That is something I'm going to talk about in a second, toward the end. Jay, good question. But yeah, protein. Protein is a big thing in terms of decreasing our cardiovascular disease risk and obesity. And maybe Akshata will also talk about that in her next talk. But going back to cholesterol, this is what's going to cause atherosclerosis or narrowing in our arteries. Okay, so the LDL is going to cause damage to the walls of the arteries. It's going to form a plaque that gets exacerbated by factors like high blood pressure and smoking, cause inflammation, and then you'll get a thrombus or a clot that's going to acutely occlude that artery and cause death of the tissue that it's supplying. Okay. Cholesterol causes coronary artery disease, but aided by high blood pressure. These studies come from the 40s or 50s, from the Framingham study that I was talking about earlier, where you can see that you need both to kind of create disaster. So if you have high cholesterol and high blood pressure, your risk of heart disease goes up significantly. Okay, so they're linked, but cholesterol is causing these plaques to form, and then inflammation, stress, and high blood pressure is causing those plaques to form a clot. Okay. LP little a or lipoprotein A is another newer form of cholesterol that we have started to learn about in the last few years. I don't know if anyone has heard about lipoprotein A, but it's kind of all the buzz in the cardiology and medical world. It's a newly discovered molecule that's genetically predetermined, as you know, which is different from like LDL, in that comes from food and also genetics a little bit, but you can kind of modify it. But high lipoprotein A levels are an independent risk factor for cardiovascular disease. 1 in 5 people worldwide will have high lipoprotein A, and unsurprisingly, genetically, South Asians tend to actually do the worst at this. It's not modifiable, not like our cholesterol that you can start Lipitor or a drug or change your diet and bring that LDL and other cholesterol down. Once you have a certain amount in the blood, that comes from a gene and that's there to stay. And so we don't have any drugs to treat this yet, but the current paradigm clinically is that when people have elevated lipoprotein A levels, we try to aggressively bring down all their other risk factors for heart disease. We try to bring down their LDL. We try to make them, stop smoking, exercise, yada, yada. And then, we tend to have our normal cholesterol checked once every year, once every few years at the doctor, but everyone should have lipoprotein A checked just once in their lifetime. Okay, so ask your doctors about that. Okay, the third question really is, I'm curious as to, I know I'm a little bit behind on time, but ways that we can reduce our cardiovascular disease risk. And I think I might skip the participation and kind of just get right into it. I don't know if people have heard about Life's Essential 8. This is the American Heart Association's validated, data-driven kind of recipe for success for lowering heart disease risk. It has 8 factors that we need to focus on to optimize our risk profile. And it used to be Life's Essential 7, but then with sleep, it became Life's Essential 8. That's why sleep is kind of magnified here. But things that we know: diet, activity, smoking, weight, cholesterol, sleep, blood sugar, blood pressure. These are the 8 things that we need to focus on. So really, kind of just to drive home this a little bit more is that, when we see patients in clinic, we tell them to get moving, to eat a healthy diet. We want to talk to you about your blood pressure, your hemoglobin A1C, which is a marker of diabetes, get your cholesterol checked regularly, and then we want you to be asking about lipoprotein A and seeing if that's something that you should have checked. But really the answer is yes. And then, I'm going to show you this with data in a second, but it's really small efforts across a lifetime. You don't have those produce great results. You don't have to drastically change things. We like to focus on small efforts and then thinking about quality of life as we age, not just how old our ancestors lived to be in a wheelchair after a quadruple bypass, right? We want to talk about quality. Okay. I'm gonna maybe table this because we have Akshata here who can talk way more in depth about nutrition. But to Jay, your question about protein, high carbs. Our body, when we eat a very carb-rich diet, especially at night before bed, that is easily stored as fat when we don't use it. So our ancestors would eat, like in the morning, rice and ghee together with sugar in it, eat a bowl of that, and then go farm for 8 hours in the hot sun. Those carbs turn into sugars in the blood, and then they used that, burned that right off, and that was quick energy. Protein and fat are more long-term energy stores, to form kind of building blocks of muscle and tissue. Those are things that we can eat and put away and use and store a little bit more healthily, especially protein. And really, there's a lot of focus now on high protein, low carb diets for weight loss. The problem becomes, in specifically the South Asian context, is the way that we're eating our protein, is that the meats are doused in cream and butter and in this curry that has a lot of ghee. And, that creates problems. And then also red meat over lean white meat can cause, there's a link there between plaque formation. And so people like in, Muslim countries that eat a lot of beef that are very fatty and very high in kind of different muscle fibers that are more red there's links between that and worsening outcomes. Okay, so we'll table this. But it's not all bad news here. I think I've been kind of droning on and scaring you with statistics, but really just a little bit of exercise goes a long way. This graph here is looking at all-cause mortality, and on the x-axis is the amount of physical activity. Obviously, the more physical activity that you do, the less your mortality rate will go. And the biggest jump here is on the left when you go from 0 to 5 Met hours per week of physical activity. Okay, that drop there in all-cause mortality, about 30%, is bigger than people who are running marathons and then do a triathlon. Okay, it's really just you sitting on the couch and then going for a walk around the block that's going to drive a lot of that down quickly. And people who do exercise, the ones that benefit the most in the research are people who are worse off, people who are more sedentary, have more shortness of breath, or have worsening risk factors. Those people are the ones that need to get moving because they will derive the most benefit from even small amounts of physical activity. Okay, we always say the most important step that patients can make is just the first step off the couch out the door. And even if you have a heart attack, say you're healthy, you're doing a lot of physical activity, you're doing a lot of aerobic exercise. Patients that do a lot of aerobic exercise and then unfortunately end up to have a heart attack do much better than those who were not doing exercise. They have decreased cell death, better outcomes, better heart healing, and things like that than patients who weren't doing a lot of aerobic exercise. And so even if you have a heart attack, God forbid that happens, if you're active before that, you are statistically more likely to heal better than if you weren't doing exercise. Okay. Now, I'm a cardiologist, and so I'm going to, of course, push drugs on you guys, but lipid-lowering therapies bring down heart disease risk, period. The lower your cholesterol is for a longer period of time, the better we are going to do with heart attack and stroke. There's a lot of fake news out there that pseudoscience saying that, oh, don't lower cholesterol, it's going to cause dementia and whatever. Like I said, to grow you from 2 cells to a baby took only 10 molecules of circulating cholesterol. We do not need 100, 200, 300. God forbid people have 300, their cholesterol is 300. We do not need that much. Okay. On the left is just trial and trial again, showing that as we lower our LDL with medications, heart disease risk in a linear fashion goes down. Okay. And then on the right, basically, again, for longer periods of time with lower cholesterol, heart disease risk gets lower. Okay, it's that simple. So we say in cardiology, there's a cumulative benefit from maybe getting on a statin earlier or focusing even at very young ages in your teens and 20s, getting that cholesterol as low as possible. Okay, even though traditional risk factors and your primary care doctor might not be aggressive about it, we say prevention wise, get it down. Okay, whether you do that by diet, exercise, whatever, we in South Asia have genetics that cause it to be higher. Bring it down, no matter how you do it. We want to bring it down ASAP and keep it down for throughout life. Okay, and so we say, put here, the lower the better for sure. Okay, and the longer the lower the better is what we're looking for. Okay, and here's another example of that. Basically, that there are some people that have mutations in their cholesterol forming genes in the liver. And this study showed that patients with mutations that bring it down 15% for their life have a 47% risk reduction in coronary artery disease. And so if you're thinking about, playing the stock market or whatever, this is like a low risk, high reward thing to do. Bring it down just 15% and you get 50% reduction, 47% reduction throughout a lifetime. Okay, so those are good odds. And then here, basically, I'll kind of go a little bit quickly through these slides, but basically, people with higher genetic risk, i.e. South Asians, have more to gain from lowering their cholesterol early, okay? The graphs here basically are showing that compared to people at lower risk, if you have higher risk of heart disease and stroke because of genes, bringing your cholesterol down is going to give you maximum benefit compared to those who have lower risk. Okay, so again, just more evidence to support that. Okay, and then kind of wrapping up here, the signs and symptoms of heart disease, if you don't prevent it, it's important to recognize and get to the hospital immediately. This is an EKG on the top right, and then kind of the mechanism of damage and things that we measure when you go to the hospital. But, chest pain or discomfort is the hallmark. We often describe it as like a heavy squeezing pressure in the center of the chest when patients have a heart attack. That can sometimes radiate to the arm, the back, or the jaw, usually on the left side. Some patients will literally come in and they're like, "Doc, it feels like there's an elephant sitting on my chest." That's a typical dull pressure that people feel. Shortness of breath, decreased activity tolerance, fatigue, weakness, sweating, lethargy, leg swelling we see. Even when the electrical system gets affected, we can see palpitations, lightheadedness, fainting. And then women and the elderly, and those interestingly with diabetes, have often atypical warning signs. And these are often missed by us in the hospital. But, an elderly woman they can come in and they say, "Oh, my stomach's been feeling a little bit weird for the past week. I've had some indigestion. I'm burping more." Those patients you want to work up for heart disease too, okay, if it's likely. And so really, there's a lot of growing data and interest in studying this topic in the United States. And so there's a lot of, new groups and things that are forming. The Masala study is very big. That's based out of, I believe, Northwestern University in Chicago. They're looking at, mediators of increased heart disease risk in South Asia. Very, very powerful group putting out a lot of research. And then our center at MGH we're running the Our Health study, where we're looking for genetic biomarkers of increased risk to kind of study why a lot of these genetic risk factors are happening. And so I encourage you, if you have the bandwidth and the time, to go to our website, become a participant, and if you're willing, we would love to take your blood and analyze it. It'll help future generations in terms of understanding how to better prevent this stuff. I just want to thank SAHHI, South Asian Care, and then my mentors, Dr. Natarajan and Bhattacharya. They weren't able to be here today. And thank you guys for having me and listening to me drone on and on about this clearly very important topic. And so with that, I will stop sharing my screen. Sahini, I believe I will try my best to make you the host. And then I'm here for a few more minutes just to answer any questions that you guys have that you weren't able to put in the chat.
Yeah, thank you so much, Dr. Chaudhury. That was very informative. And we, of course, Thank you for your time and hope to work with you again in the near future. That said, yes, please leave your questions if you have any comments or anything like that in the chat. If not, Dr. Chaudhury, if you can also put in your email in the chat for everyone, that would be very helpful. So that said, next we will pass the light to Ms. Akshata Nayak, a nutritionist and integrative health specialist. She will discuss the important connection between gut health, nutrition, and heart disease risk in our communities.
Well, I'm the host now, so I guess I can do whatever I want. So, hi everyone. Rich, thank you. That was amazing. I loved learning about some of the studies and stuff that you're doing. So, I'm definitely going to be looking that up, and your Our Health group as well. So, thank you for all of that. I hope I'll be able to answer some of the nutrition questions that had come up, and you jumped over some of the slides. So, I hope I do well in what I need to present. So, let me just get ready here to share my screen. Can you see this okay? Can somebody put in the chat if you can see this okay? Okay, great. Thank you, Nishat. And I will. Okay, well, so my name is Akshata Nayak, and I'm actually in Vermont, and I run Alternative Roots Wellness Center with my husband, and we offer nutrition and chiropractic services here. I have a master's in applied clinical nutrition and a master's in biochemistry, which I'm always very excited about because it allows me to apply information that comes through, new studies and things like that, and find a way to make that practical and how to apply it in our daily lives. And something that I end up talking about a lot with my patients is the connection between your gut and your heart, and how that you can help your cardiovascular health by taking care of your gut. So I wanted to talk about that, especially in relation to South Asian health today. So, Dr. Chaudhury went over this. I'm very quickly skimming over it. It's relevant for South Asians because of the higher risk that we have, up to 10 years earlier that we can develop it at what can be considered normal BMI and cholesterol levels. And this is usually because of dietary patterns that we have intersecting with genetic predispositions. So the genetic predispositions that we end up with put us with high triglycerides, high low density lipoproteins, higher of the lipoprotein little a, as Dr. Richard talked about. Unfortunately, lower high density lipoprotein, the HDL, higher insulin resistance, and higher visceral fat, the fat that's around your organs, not the fat that you see immediately, under your skin. This is biologically active. It produces a lot of inflammatory molecules, changes hormones, all kinds of things. And so that all of these things put us at a risk of developing cardiovascular issues more than other ethnicities. And so when something like this happens and I work with patients, my question or the way I approach it is always trying to think what can be done from a nutrition perspective and what can be done from a gut healing perspective for this person. So there is a connection between gut and heart, and that's because the gut can influence the heart via the changes that happen, especially in the microbes in the gut. And this is kind of what I'm going to focus on. There is so much that I can talk about. Each one of these, in fact, when I do workshops, like just talking about the microbes in our gut is one whole separate presentation I do. Each of the things about inflammation, each one of those are like hour-long presentations I do. So I'm just going to focus on a few things rather than trying to skim over a lot of different things. Any questions, I'm happy to answer it as needed. I may miss things in the chat, so I can look at that at the end of it. So the gut influences the heart because of changes in the microbes, which can then affect your heart through the immune system through the metabolic like byproducts that these microbes produce. And they also affect insulin regulation, which brings in the whole diabetes factor into consideration, like Dr. Richard talked about. All of these things increase inflammation in our body, and anything that increases inflammation in our body starts affecting how our vascular system works. And so trying to keep these contained, very important. And in fact, dysfunction in the gut through these things can directly contribute to atherosclerosis and insulin resistance diabetes. So what is dysbiosis and what's the connection to the heart? Dysbiosis, it happens in the large intestine, which is the location that we have all the microbes in our gut. Rather, that's the location they should be in. Anytime they're outside of that, it causes a lot of problems. There's nearly 5 pounds, like trillions of them. In fact, it's considered almost like a whole other organ now. Over the last decade, I would say there has been a ton of research that is being done into these. Of course, a lot of that is fueled by trying to find, pharmacology, ways, drugs and other things that can be used to affect them. But I think it's very interesting, the information that's been coming out from it to help us understand how vital this actually is for us. They're not just hanging out there and doing nothing. They, in fact, contribute a lot to our health. So the happy campers are the good guys. These can be bacteria. There can be even types of like fungus that are important to us. But the good ones produce vitamins and other beneficial compounds. You also have unhappy campers who are the bad guys, and they cause a lot of fermentation, the gas buildup. It can increase toxin load and things like that. An imbalance of gut microbes basically means that you have less diversity of the types of microbes that are there. You need a varied variety to be healthy. And so the less diversity there is, the less healthy it is for you. Or it's either less diversity or you have more of the harmful species, which you then need to, do a check on. And you can also have overgrowth of microbes in the wrong region. In fact, this can sometimes happen in the small intestine, and that's called small intestine bacterial overgrowth. And that can cause a lot of digestive issues and a lot of gas and bloating and things like that because they're not supposed to be there. So all of the function that they do in the large intestine, which can be beneficial, when they do it in the small intestine, it's not beneficial anymore. So the causes of dysbiosis, and I think these are ones that relate to us as South Asians more. So these are the ones that I'm highlighting. We can have lower fiber in diet, which can seem surprising mostly because we have so many ways of getting fiber in our diet, but we still tend to have a lower fiber diet, a higher starch diet, a higher fat diet. And medications that seem to be prescribed at higher rates for South Asians because of all of the, risk and comorbidities and things like that that Dr. Chaudhury had touched on. So antibiotics, antacids for indigestion, including proton pump inhibitors, statins, metformin for diabetes. So continued use of these medications ends up causing the dysbiosis in our gut, which sort of leads us down this path of having more of the unhappy campers and the bad guys in the gut that release products that in turn cause inflammation and can affect our cardiovascular health. So even though they may seem, they're such small little things, they can, through this process, affect our overall health. So they do this, one, through the immune system, the gut microbes. What I always find my patients are surprised by is to learn that most of our immune system is associated with our gut. And not a lot of people know this. Around our gut is some of the largest portions of our immune system, which means that if something's inflamed here or it's not, it's unhealthy here, it gets magnified and it has far-reaching consequences for our body. And it can also cause something called leaky gut. You can have intestinal permeability and cause leaky gut. And you can start reacting to microbial components from food contamination or from overgrowth of the bacteria that can slip through the cells. And you can start having reactions to that. And this is how people who weren't allergic or sensitive to foods before can become allergic or sensitive to foods later on in life, is because of the development of this leaky gut. Which basically here, if you see the cells, they're tightly packed and they have these finger-like projections. Those help in absorption of nutrients and stuff like that. This is in the small intestine. So the cells are very tightly packed and they have that beautiful brush-like border. All of that helps us absorb, break down, do all of the digestion processes that we need. What happens in leaky gut is you have larger gaps and there's a breakdown of those brush-like borders. So you have less surface area for absorption of nutrients, and plus stuff can get through. I'm not talking about like a piece of food getting through. By the time you get to this point, usually digestion has happened enough that we're talking about microscopic, right? And so you can have pieces of the proteins and things like that coming through, and your immune system's right under there through the blood. And because of that, you start having reactions to all of these things, and you can develop toxic loads, you can develop food sensitivities as well. So basically, to try and maintain our heart health, we need to keep our cholesterol down. We need to keep inflammation down. We need to reduce insulin resistance, visceral fat, and dysbiosis. These are things that we need to keep in mind. And the way I look at it is that for all of these, it's important to heal our gut. And so healing the gut is we do something called the 5R program. And I'll go through each of the steps of this. There are 5 steps. You remove. The first R is remove. What do you remove? You remove pathogenic organisms, allergens from your diet. So making sure, if you are somebody who has some sort of, exposure to things like mold and stuff like that, that you're taking care of that. You're making sure for toxins, you're not heating food in like plastic containers and stuff like that. You're making sure you're not doing those things. And if there are foods that bother you, please stop eating them. There are so many people that I see that say, oh, when I eat this thing, I don't feel that great the next day, but it's so delicious, I eat it anyway. If food bothers you, even if it's not immediate and it's a delayed reaction, please stop eating it, because you're continuously irritating your gut. So the first R is the elimination of all of these things. You may need a food antibody test maybe to determine what allergens you have. And these are something you can talk to your doctor about. You can talk to a nutritionist. I'm happy to help you figure this out if you're interested in talking to me about it. And if you don't want to do a test, then you can just start out with the most common allergens and follow a hypoallergenic diet for a period of time. And that's taking out like dairy, peanuts, corn, wheat, soy. So the top, 5 to 6 foods that a lot of people are allergic to, take those out and see how you do. And then you slowly reintroduce them and see if any of your symptoms come back. If you started feeling better when you eat these things, if you feel worse, then you know that that's something you need to be careful with. I'm not one who says that all people need to stay away from gluten or all people need to stay away from, a particular food group or a whole class of stuff, mostly because I think it can be so individual. And even talking about like South Asians in general, I would say in this list, there is a higher incidence of lactose intolerance for us. So being careful of dairy or being cognizant that you may be lactose intolerant and taking, the enzymes to help you with it, that itself can be a huge step. But other than that, there really aren't like blanket foods or anything I would say all South Asians need to avoid for any reason. It's a very individual thing. Removing what's irritating your system is very important in fixing it, right? If you do all of the other steps, but you don't remove what's irritating you, it'll continue to irritate you, even if the effects aren't as magnified because you've done the other things. You'll continue to develop that low level of inflammation in your body, and it'll continue to have that longer lasting, effect on your cardiovascular and other systems. So then the next step is R. The next R is replace, and that is adding in the factors that may be deficient in the individual. And in this case, it's things like If you have problems with digestion, adding that back in, it can be, protein digestion, fat digestion, adding those enzymes back in, adding bile back in, if you're especially somebody who's had their gallbladder removed or anything like that, making sure you're producing enough stomach acid. And also there are certain, herbs and spices that we have in our diets that can be really beneficial. Ginger, hing, ajwain. These are things that we use in our foods. Ajwain, jeera, those types of things are, I've always heard older people say you boil that in water and you drink the water, and that's really beneficial for digestion. There is something to it. But if you are somebody who's suffering from dysbiosis and has all of these other things going on for cardiovascular health, you need a stronger approach than just sort of, adding a little bit of this into your diet. But it's something that you can certainly start using more of. Testing may be necessary to determine what factors can be added back. If you're interested, you can go through the testing, but more often than not, the symptoms that you have from being unable to digest these foods can tell us that something's missing. So if you're not able to digest protein very well, it's usually lower stomach acid production. If you don't have enough stomach acid, you tend to burp more. You have more it seems counterintuitive, but you can have more reflux. If you're unable to digest fats, you have anytime you eat even healthy things like nuts and your stomach does not feel right, or you feel bloating or cramping, that means you need some bile substitution. So getting a very detailed history from the patient, especially about these types of digestive symptoms, really points us in the right direction of what needs to be replaced in their system. And this is essential to make sure that all of the food, the supplements, anything else that you may be adding into, even medications that you may be taking to support yourself, making sure that it can actually be used and absorbed in your body properly. The next R is to reinoculate, and this is all of the bacteria and the different types of microbes. And so reintroducing that as probiotics from supplements. This is a time when I insist that supplement will be better because the type of the beneficial bacteria and all the others that you need, the dosages that we use are in tens of billions, and what you get from fermented foods is in the millions. So it's a significant difference in what you can get from food versus supplement. And if you need to see a direct relation to your health in a very specific manner, then you need it from supplements and not only from food. And then you want to support the good microbes. And you can do that with things like, eating a high fiber diet, onions, garlic, asparagus, chickpeas, methi, the seeds. All of these have components in them that help keep the happy guys in our body happy. And we should do as much as we can to keep them happy. And this is important. This process of re-inoculating the good guys back into our gut is important to maintain the health of the intestine. I had talked about the small intestinal bacterial overgrowth, the SIBO or SIBO as it's called, very briefly early on. And you want to make sure that that has been addressed before you start adding things back in for probiotics. And the way to address that sometimes, depending on the individual, can be an antibiotic treatment. And there are also other like herbal remedies and things that people have tried. I usually tend to work with somebody who's working with their physician to do an antibiotic treatment and then make sure their symptoms have reduced and then continue working with adding all the good guys back in. And then you have repair is the next R. And this is basically finding ways to heal the gut lining, the stuff that had broken down and the gaps were bigger, the finger-like projections had broken down, brush-like border, all of that you need to build back up. And for that, you need certain nutrients which really support that. Glutamine is in homemade broths and soups. This is, vegetarian or meat-based, but making it at home. They have higher quantities of glutamine when they're packaged in like cans or in the Tetra Paks than the heat levels that they go to make that shelf stable sort of destroys some of this. Vitamins A, C, and E, and this is in like citrus fruits, red and yellow bell peppers, which I think, should start adding more into our subgis and stuff like that. Carrots, nuts, seeds. You need some minerals, which are extremely high in green leafy vegetables, which traditionally are things that are used pretty often in Indian cooking, which we've lost a lot of that. So bringing those back in. And another nutrient called glutathione, which is in like jeera, asparagus, potatoes, garlic, tomatoes. Garlic's quite an interesting superfood. I love it. Anything that requires garlic usually gets like tripled in my recipes. But it does have a ton of different benefits to it for sure. And then the last R is rebalancing, and that is establishing long-term lifestyle habits to support the health of your gut and in turn, your cardiovascular health. One of these things, it's like consistent meals, basically, consistent meals through the day, not having huge gaps in between your meals within a day. Eating earlier in the evenings. South Asians tend to eat late at night, their meals, and sort of go to sleep very quickly after that. It's better actually to have an earlier dinner time and not have a lot of food just before you go to bed. So sort of pushing that up a little bit is very helpful. Restful sleep. Some of us tend to sleep for like 8 hours or more, but when you wake up, you're still just as tired as when you went to bed and you feel like, oh my God, I could have slept for a few more hours. That's not restful sleep. So trying to get restful sleep by managing your stress and making sure other factors are taken into consideration. Why are you not getting restful sleep? Do you wake up often through the night? Do you need to pee? Are you having hot flashes? Like what's happening? All of those symptoms tell us what else is going on in your body that needs to be addressed. But the sleep and stress management are critical in maintaining your health overall, affecting your gut, affecting your heart also. And I would say, in terms of overall nutritional changes, my mantra is always real, whole, and simple. So eating real food. Trying to stay away from processed and fried, like packaged foods as much as you can. Of course, convenience makes it necessary that we use those sometimes. And then you try and find the best options within the list that you can. You're not always going to be able to completely stay away from it, but trying to eat real food as often as you can in its whole state, not as processed and cooked simply. The idea of good food is not related to complicated processes of cooking it. Just a quick tadka of like jeera and adding a vegetable into it with a little bit of haldi and salt, like that can be a very easy stir fry that anybody can do. And in fact, I've got a lot of my patients who are non-South Asians using a lot of like jeera and those types of things when they're doing quick stir fries for their meals. So I'll, instead of looking at calories and percentages and things like that, which a lot of people find difficult to maintain on a regular basis. And I also don't like to give people caloric lists or numbers when I do presentations, mostly because I think that those are all very individual recommendations. And when I put a number up, that becomes the focus for a lot of people. And I don't like making that happen. So instead, what I like to tell people to do is to look at their plate and see what that looks like. You want it to be mostly fruits and vegetables. And even in that, you want the vegetables to be more than the fruits. Right. And these are a ton of your, like as many colors of vegetables, more of the greens that you can get, the darker colored vegetables, the better it is. You want a little less than a quarter to be, your whole grains. And this can be like, it can be rice, it can be brown rice, it can be, if you're doing whole grain rotis and things like that, it can be all of that. Again, I'm not one to say everyone has to stay away from gluten. If it works for you, great for you. I will live vicariously through you because gluten does not agree with me, unfortunately. But for people, those who can eat it, please enjoy. And about a quarter of your plate should be protein. So if you're thinking about like dal and things like that, it can be about a cup to a cup and a half. If you're thinking about meat, then, it should be just a quarter of your plate. It shouldn't be the main dish. The main dish you cook should always be the vegetables and or fruits that you have. Have a mixture of raw and cooked. That will also be very beneficial. There are different healthy fat sources that you can include, which is, eating avocados or avocado oils, eating nuts or nut, oils from that, seeds, and their oils, coconut oil, sunflower oil, olive oil. I would say out of all of these, coconut oil, not as much. Ghee is one of those things where it's definitely come up in prevalence, as well as butter, which was like on the cover of Time magazine at some point saying it was back. So it can be really misleading and confusing for a lot of people. The idea is always the way I tell my patients to look at it is focus on what you're doing for 80 to 90% of the time and improve that as much as you can. The other 10 to 20% is going to happen, and you need to have some sort of space in your life to be able to, move away from rigidity, and that's okay. So if you're using coconut oil sometimes, if you're using, ghee sometimes, that's fine. If you're using these on a regular basis, then that is where the problem comes in, especially for South Asians who have all of these genetic predispositions towards all of these risk factors. So we just need to be more careful given we have that already going against us. Now, also, if you have a genetic predisposition to something, it doesn't mean that that is, the final word. The way you live your life, the food you eat, the lifestyle you have can turn on and off genes as well. So how they express, that can be changed, modified to a certain degree, not fully, but to a certain degree. And so you try and do the best that you can in all of these different ways to give yourself the best chance, right? This is all kind of hedging bets. You're trying to change percentages here. And so that's why I say that what you do most of the time, pay attention to that, see what needs to be modified. What you do for like 10 to 20% of the time, one day out of the week or something, that won't affect your health as significantly as the other stuff will. And then water is always going to be your best beverage, because it does the hydration without all the extra stuff. You can have, yes, coffee is there, but coffee can be dehydrating. So you have to make sure you replace that. Same with alcohol. You can have like broths and soups. You can do all of that. But in terms of hydration and things, water is going to be your best beverage. A lot of people like coconut water and stuff. That's great. Again, not on a regular basis. If you're having it once in a while, that's fine. Packaged stuff sometimes can seem sweeter. So just, be careful about that. There are a few things that I wanted to highlight here for especially our diets, South Asian diets, is talking to you guys about the importance of fiber. That's one. The second one is something really cool called resistant starch. And I don't know how many of you know about this, but I'm really interested in sharing that with you. And of course, fermented foods and what they can do for us. So starting out with fiber, you need to start to love fiber-rich foods. We need to be including this way more in our diet than we do. In fact, whatever you're doing, at least double it now. It's a type of carbohydrate that our body can't digest. We don't have the enzymes to digest this. Certain other animals do, we don't. There can be soluble fiber, which dissolves in water, and this helps lower glucose levels and helps our body actually lower cholesterol levels because the fiber binds it and helps get rid of it through the bile. And so examples of these are like oats, chia seeds, nuts, and beans, lentils, apples, blueberries. These are very high in soluble fiber. So this can really help address cholesterol. If you have problems in getting rid of cholesterol. There's a lot of cholesterol circulating in your blood. A lot of that gets converted into bile salts, and the soluble fiber helps pull that out of your body. And so that's very important for that. And there's insoluble fiber, which does not dissolve in water. It just helps food move through your digestive system. So it's preventing constipation, and that's vital because you're not getting a backup of everything in our body. It keeps the gut healthy and happy, and it keeps the happy guys happy, which is good. It reduces inflammation and therefore can improve cardiac health. So this is whole wheat products, quinoa, brown rice, legumes, leafy greens like kale, mustard greens, Swiss chard, and all of these other traditional greens that we can use in our cooking. That has a lot of insoluble fiber. So soluble fiber and insoluble fiber together can have a huge impact on our health. You want to try and get like 45 to 50 grams of it. I think, most of us don't even get to 20. So you want to try and at least double what it is that you're having. And so this is a great quick way of improving your health is by increasing the fiber in your diet. If you are somebody who has lower fiber in your diet and you're looking to increase it, I would suggest doing it over time. Don't suddenly start eating like a kale salad every single day, because that will cause some gas and bloating, because that is, affecting the microbes in your gut and they need some time to adjust and balance. And so do it over, 2 to 3 weeks. And that'll be a gentle way to sort of increase the amount rather than suddenly just going bam and having all of this stuff. So just be careful about that. Resistant starch. I don't know if any of you have heard of this, but this was some of the coolest stuff that I, studied when I was in college. I was very excited to learn about this. So these are starches that are resistant to digestion, as their name says. Most starches, the carbohydrates, our body breaks it down in the small intestine. Starting from saliva, it goes into the small intestine. It breaks down completely and things get absorbed. It results in an increase in glucose in our body. However, resistant starch does not do that. It moves, there's no glucose spike, so there's no insulin spike, and it can actually help maintain insulin sensitivity in our body. Because this resistant starch, it moves past the small intestine and almost like fiber gets fermented in the large intestine rather than getting digested in the small intestine. And this supports the good guys in our gut. So this is really cool. And what is fun about this is how it exists in foods, right? So some foods already have them, and some foods develop them when you cook and cool them. And so here are some examples, right? Rice, you cook and cool it, it becomes resistant starch. Potatoes, you cook and cool it, it becomes resistant starch. Legumes, rajma, chana, tur, moong, all of the whole grains we use, pasta, sevaya, sweet potatoes, all of these things, you cook it till it's cooked, you cool it, put it in the fridge overnight. All of the starch molecules in that undergo a process that changes their structure to now they go from regular starch to resistant starch. You can heat these foods again. There is some change in the amount, but the resistant starch is still significantly higher. So if you want to eat these foods, cook it the day before, put it in the fridge, eat it the next day, right? All of that now has become resistant starch. Aloo sabji, cook it, put it in the fridge, eat it the next day. It's resistant starch and it's not simple carbohydrates. I think that's pretty magical. And then you have things like raw banana or, plantains. Those already have resistant starch in them even before you cook them. So cooking them, you're even getting that benefit. That's why for a lot of people, eating plantain is not easy for them, especially if they don't have a very high fiber diet to begin with, because that has so much of this fiber, this resistant starch thing in it that goes to the large intestine for fermentation that their body can't handle it very easily. So I think, this is one of the coolest things that my patients find when I talk to them about how to prepare something so that it's more beneficial for you. This is something that we can do. And it has to be refrigerated and fully cooled for this to happen. It's not that, you make it and keep it outside and then you eat it a few hours later. It has to be fully, completely cooled. And that's when it happens. And then, of course, fermented foods are significant in our diet, in our tradition because of dahi and other pickles and things like that. So it's a controlled process of growing microbes in food, and the enzymes that they produce break things down to give a texture, flavor that and other characteristics that are loved. There's a traditional way of doing it, but of course, you can, for convenience, you can buy it. That doesn't really change things as much in terms of benefits, really. Examples are plain yogurt, Greek yogurt, lassi, buttermilk, pickled vegetables, fermented batters that you can use for dosa and stuff like that. But what I want you to remember is that if for any reason you need support to help increase the beneficial microbes in your body, you can't do it only through fermented foods. You can use this as a support, but you need supplementation as well there. Probiotic supplements are also very specific in the effects that they can have. Like people with Crohn's need specific type of probiotic supplements. People with other types of IBS will benefit from something else. So depending on what your symptoms are like, depending on what are all the conditions you're dealing with, the types of probiotic that you may need, the types of microbes that you need could be different from the, others. And so it's very important to make sure you're getting the right supplement for it. I wanted to share a 1 week meal plan with all of you. And the way I like to think about this is thinking in threes. So I have my patients think of 3 breakfast options, 3 snack options, and 3 dinner options, with the idea that the dinner leftovers become lunch, right? So you think of it this way, and you make sure you're making enough of this to last you, of each meal to last you for the week. And then you follow a chart like this. It looks complicated with colors. I will put it up in just a second. It looks complicated in colors, but I will walk you through it and you'll see it's basically you're just alternating things, right? So you have 3 options for breakfast, and I'm going Monday, Tuesday, Wednesday, left to right. So you alternate breakfast 1, 2, 3, then you go back to 1, 2, 3, 1. Snacks, I usually suggest, again, depending on the individual and what your day looks like and stuff. Most people require 2 snacks in the day. So you have snack 1, snack 2, snack 3 the next day in the morning, snack 1 in the afternoon, and then you keep alternating that in a zigzag pattern. And then for dinners, again, it's basically dinner 1, 2, 3, 1, 2, 3, and 1. So you're just alternating these dinners. You have leftovers as lunches. You have 3 ideas for breakfast and 3 snack options. Especially the snacks, have something that's ready, because this is the time where we tend to just reach for something that's convenient. When you're that, you just need something quickly. It's best to have something ready. And so, ideas that I had was for breakfast, there's no rule written anywhere, and I'm not sure how this came to be, that you have to have only certain foods for breakfast. You want to have dinner leftovers for breakfast, enjoy, have a blast. The idea is to make sure you're having a balanced one. If you're somebody with cardiovascular concerns, as Dr. Chaudhury had talked about, you do need a slightly higher protein content, making sure that you're getting, a lot of fiber in your diet. And that you're getting good combinations of things, that you're not eating things in isolation. So don't sit and have like a bowl of rice. But if you have a bowl of rice, leftover rice would be better for the resistant starch, combined with some sort of dal and a vegetable that balances it out. Don't just have dosa and chutney. Have dosa with some sort of vegetables. You can always have it with sambar, idli, sambar. You can do that. Dosa and some type of curry. You can always do that. I know that it's not always traditional to do it that way, but when you come up with these combinations, it's better for you. So options for breakfast like moong dal, chila, which are just like crepes with it, and having it with a little bit of yogurt is always, a great idea. You're getting fiber there, you're getting protein there, you're getting, some of the fermented foods as well. Overnight oats ends up being really high in resistant starch because oats are have resistant starch. And so and soluble fiber. So you're getting a lot of that, and you're adding chia seeds in there. And you can do this with like mangoes and elaichi. It's almost like amras, right? And so you can do that for overnight oats. You can do idlis and dosas, and instead of making it only like fermented rice, you can use millets, you can use lentils, like moong dal dosas and masoor dal dosas and stuff like that. And you can, those fermented batters. So it's giving you that benefit of the fermentation, and then you can have it with mixed vegetables as sambar or any other option that you would like to have with that. And then snacks, roasted chana, that's so easy to do. You can do it yourself. You can find different versions of it. If you're buying it on, in stores, then you just want to make sure that it's not one that has a ton of oil or, other ingredients to it. Roasting it shouldn't really add or require a lot of oil and other additives. You can do roasted pumpkin seeds. You can do roasted makhana, all of the lily seeds, what are they called, right? The makanas, you can have that. A sprouted moong salad. So you sprout the moongs, and I usually mix it with like the chutneys, a little bit of the green chutney, a little bit of the imli chutney, and then a little, chopped up onions and chopped up tomatoes in there. Like that makes a really nice salad. And you can just have that. And you can even put that in a little pita pocket if you would like, and have it as a little wrap as lunch if you don't want it just as a snack. And then fruit and nut mixes, and any fruit, have that with a little nut mix, and that works. And pistachios, which South Asians tend to like, those are higher in protein and lower in fat relative to a lot of other nuts. And so they're a great option to add into your diet as well. And then for dinner, like a rajma chawal, there's nothing wrong with that. You don't want to have like big giant, steaming hot pots of rice with, a lot of rajma and stuff. But having a little bit of chawal and some rajma, and making sure you're also having a green vegetable or a dark colored vegetable with it, like that's a good meal. There's nothing wrong with that. You want to make sure you're cooking all of this stuff without, all the cream and like that. If you just crush some of the rajma after you cook it, that'll give it the creaminess. You don't need to add all of the cream and other ingredients into it. That's not the only way to make that happen. Or, chole with any of these legumes. You can have it with a bajra roti instead of a regular roti, and do a leafy green sabji. A spinach sabji or Swiss chard is something you can get easily here, that can be turned into, just sauteing it with a little bit of garlic and onions and putting in cut leafy greens at the end of it. That makes a delicious sabji to go with something like this. You can do roasted fish, you can do roasted meats, or if you want to do a curry which isn't cooked with a lot of like oil and that kind of stuff, which is a simple curry, onions, tomatoes, are masalas, and the meat. If you're doing something quick and simple like that, you can have that with quinoa and like a garlic eggplant stir fry bengan, and that works really well as well. So thinking about your week as 3 breakfast options, 3 snack options, and 3 dinner options that you can make a lot of and keep maybe on the weekends, if that's when you have the time. That's usually when I do it and when I encourage my patients to do it. I also try to think of ideas where, okay, I can put the rajma in the instant pot. I can cook a dal in my pressure cooker, and I can roast vegetables in the oven, and I can make like a chicken curry, right? So you have a few different things going on at the same time. So you're not like waiting one after the other. You have to cook because you don't have space on the stove top, you don't have enough pans. Then if you do have, most of us tend to have a pressure cooker, we have a pot that we can use. And then I think a lot of South Asians use like the instant pot as well. If you have both, that's great. If not, you may need to stagger it, but it's an easy way to do this and sort of plan out a whole week with just a few options. I will talk a little bit about supplements, but mostly to let you know that it's not really a silver bullet. A lot of people try to supplement their way out of problems, and that's not how it works. Just because something is called natural doesn't automatically make it safe. In fact, there is no real definition in the world of supplements for natural or even skincare. So I don't know what they mean when they call something natural, but it seems to be like a buzzword that works in marketing. And so that's what they use. But natural does not automatically make something safe. It's not a substitute. This is for a healthy lifestyle. You cannot supplement your way out of health problems. The common ones that you can use for heart health, I will list here. And what I do is I usually list food sources. I don't list dosages, because what I started realizing after doing a bunch of these workshops was that every time I listed dosages and I would keep talking about how you should talk to somebody before you take all of this, people would invariably go home and take that much of each of the ones I talked about, and then have all other kinds of problems. And so I would rather let you know what the food sources are. And if you're interested in the dosages, that you talk to a healthcare professional, your doctor or nutritionist